Hey folks, welcome back to Discussions with Dr. G. I'm Dr. G, your sarcastic professor, teaching you the meds that'll either help you or maybe make you sleepwalk naked through a Taco Bell drive-thru at 2 a.m. Today's episode is all about insomnia. So why can't we sleep? Oof, the age-old question. Insomnia isn't just tossing and turning because you had a late night espresso. It's trouble getting to sleep, staying asleep, or feeling like your pillow is a rock and your mind's running a marathon, or waking up and feeling like you got hit by a bus. Either way, none of these results in a refreshed state upon awakening. If you've ever been wide awake at 3 a.m. binge watching baking fails and wondering if you'll ever feel human again, you know what I'm talking about. Sound familiar? Well, you're definitely not alone. Now, sleep itself, it's like a high-maintenance friend. Standard sleep is divided into NREM and REM. NREM breaks down into 3 stages: N1, N2, N3. And those deep stages, especially N3, are where your body does its repair work. Then REM, which is when your brain's just basically thrown away, rave. Lots of dreaming and actually processing stuff you learned and what you felt during the day. But with insomnia, that neat little architecture goes out the window. Less deep NREM and REM and more fragmented and light sleep. So you're stuck in the shallow end, never quite hitting those restorative stages. The impact? Rough. We're talking more than just feeling groggy. Chronic insomnia can make your brain foggier than a San Francisco morning. Seriously, cognitive decline, more accidents, higher risk of things like heart disease and diabetes, the stuff no one tells you about in those commercials with people frolicking through flower fields. And before you say, I'll just live with it, untreated insomnia can tank your mood, your memory, your immune system. The risk? Just a small list. Higher rates of cardiovascular disease, diabetes, cognitive oopsies like forgetting where you left your car keys or your car, and increased mood issues like depression and anxiety. Why does this happen? Well, sometimes it's due to hyperarousal. That's a fancy term for your brain refusing to shut down. Or maybe it's circadian rhythm disruptions. Think night shift or caffeine at the wrong time. I actually spent part of my nursing journey on the night shift, and wow, did I see the real consequences. I'll never forget this one patient in and out of the ER like it was his gym. Chronic insomnia led to blood pressure spikes, bad falls, and I think we saw him about every other week for something new. Just a reminder, insomnia is not playing around with your health. So, what do the meds do for us? Basically, they try to help you conk out by either ramping up GABA, that's your brain's chill out neurotransmitter, or blocking the same pathways that keep you up binge watching true crime until dawn. And let me tell you, before I was a nurse, I tried every home remedy: counting sheep, lavender sachets, warm milk, yuck, even meditation hacks. I'd be wide-eyed until, I kid you not, the 3rd hour of Lord of the Rings. Anyway, if you're at the point where Netflix is your nightlight, pharmacology starts to look real attractive. So let's break the pharmacology down. We've got 4 main classes of prescriptions for insomnia, and honestly, choosing the right one can feel like picking a starter Pokemon. First, non-benzodiazepine receptor agonists like zolpidem and esopiclone. These guys lock onto your GABA-A receptors, specifically the alpha-1 spot, which is like pressing your brain's snooze button. They work for falling asleep, and weirdly, some forms even help if you wake up at 2 a.m. But heads up, complex sleep behaviors can happen. Think sleepwalking, sleep driving, even sleep cooking. And no, I'm really not being dramatic this time. That's the FDA's boxed warning. Fun fact, zolpidem, which you probably know better as Ambien has been behind some wild court cases because people literally do things in their sleep and wake up in legal trouble. I mean, I only sleep eat cookies, but it's still scary. Second, benzodiazepines. The classic for this is temazepam. It works by enhancing GABA all around, so not just sleepiness, but straight up central nervous system depression and muscle relaxation. It's really great if you need to relax, but I promise you, here comes the price. Dependence. It can be fierce. You don't want to mess with benzos unless it's short term. In this case, think 7 to 10 days tops. Are you pregnant? Do you have sleep apnea? Are you planning to chase this with a beer? Nope, nada, and please don't. Also, if you're caring for older adults, remember these are on the beer's criteria list. That's the avoid in grandma list because of increased risk for falls and cognitive effects. Again, these are going to be used short term. You're going to taper, slow, avoid alcohol. There is an incredibly high risk for dependence, overdose, withdrawal, and oddly enough, pneumonia. Oh, and flumazenil is the reversal agent for these, except if you're prone to seizures, because it can stir those up. Okay, did I mention short term? Okay, yeah. Third, we've got selective melatonin receptor agonists like Ramelteon. These are kind of cool. They mimic melatonin to help you nod off and keep your body clock on track, or if it's off track, it can help reset your sleep clock. It's not a knockout drug, but it is really safe long term, and it's not habit forming. So what are the risks? Fatigue, dizziness, mood changes, headaches, weird hormonal shifts like lowering testosterone or raising prolactin. Although not super common, it is a thing and it is rare. Another rarity is dangerous allergic reactions. And because it's processed through the liver and interacts with some antidepressants like fluvoxamine, not everyone is a candidate. Last up, my personal favorite for nerdy pharmacology lectures are the orexin receptor antagonists like suvorexant and lemborexant. These quiet down those pexy orexin signals that shout, "Stay awake and do your taxes" at 4 a.m. These are safer in folks with substance use disorders, but you have to avoid it with narcolepsy, severe liver problems, and if you're a polypharmacy superstar, some meds just do not mix. Adverse effects are dreamy, unless you count daytime sleepiness, sleep paralysis, nightmares, or rare cases of cataplexy, which is muscle weakness out of nowhere. And if you're taking strong CYP3A inhibitors, MedChem folks, you know we're going to skip this one, okay? So yeah, not exactly plug and play. Picking the right med means knowing the mechanism, the side effects, the risks, and how to teach your patient what to expect. Still, dependence is low, so that is a bit of a plus. So are the risks worth it? Honestly, sometimes. If you're at real risk of an accident, losing work, or like about to start sleep texting your boss, short-term use under watchful eyes can be life-changing. But every option comes with a catch, so you've got to weigh the benefits against some of the potentially weird or risky behaviors. All right, you got to know your patient. It's what it comes down to. So, you're a nurse or you're about to be a nurse, and you want to keep your patient safe. Super critical. Start by digging into their sleep history. You got to start with a thorough assessment. Check for comorbidities like, is the patient diabetic? Are they struggling with depression? Or maybe they're on 5 other meds that are also messing with their sleep. Is this a one-time rough patch or have they been struggling for months? How much caffeine are they taking in? Is there a bottle of wine on their nightstand? Substance use, med list, underlying condition, all these pieces matter. Assess, reconcile, repeat. Not all insomnia meds are created equal for everyone. Contraindications do exist. Severe respiratory disorders, a history of substance misuse, even pregnancy, depending on the class. Monitoring is an absolute. Watch for CNS depression, odd behaviors, and in older adults, falls. Because we all know hitting the floor is way more dangerous when you're 80. Client teaching is non-negotiable. Big warning. Most sleep meds are on the Beers criteria for older adults. Why? The risk for fall skyrockets and benefits aren't that great versus the side effects. If you've ever worked a night shift, you know the sound of a geriatric hip fracture, and it is unforgettable. Always do fall precautions. Reinforce that they only take meds at bedtime and never with a glass of wine. Always with enough time for a good night's sleep. Client education is where we shine, guys. Talk about dosing, never doubling up if they miss a dose, tapering off, and remind your patients if they start seeing pink elephants or develop a weird rash to call the provider immediately. Watch for new and worsening depression and make sure they know to report all those fun sleep behaviors we just mentioned, sleep driving included. The next thing you need to do is emphasize non-pharmacological sleep hygiene. This should really be the first line before medications. It sounds boring, but seriously, dark room, chill out before bed, no scrolling TikTok into eternity. If you do end up using meds, take them right before bed, never mix with alcohol, and for the love of pharmacology, don't even think about driving or operating heavy machinery if you are drowsy. And please don't double your dose if you forgot last night. Again, we're going to teach them to taper as directed, okay? Pull out the Beers criteria, question every old standing order, and look for safer options that don't leave our clients drooling all day. If you can do that, you're not just following orders. You're making people's lives actually better. Okay, off of my soapbox. That's it for today's episode. Take care of your brains, get some decent sleep if you can, and I'll see you next time for another deep dive into pharmacological options. And maybe I'll bring a story about how my cats ruined my sleep hygiene for a week straight. Till next time.